interview. To make the meeting run as smooth as possible, can I please ask that participants in the virtual meeting room to leave your microphone on mute when you are not speaking. When you want to speak, please raise your hand to the camera. Only unmute when the chair indicates that you can speak. The meeting host will bring speakers into the virtual meeting room at the appropriate time. Once you have spoken for the allotted time, the host will then return you to the public gallery. If at any time any member loses the ability to hear or be heard, they must alert the chair or host as soon as possible. You may see members looking to the left and right of their screens. This is because they may be looking at an additional screen or device containing the agenda papers, not because they are distracted. I will now hand over to the chair of the meeting.
Thank you, Jenny. I'm just going to start with introductions, and I'll just call out your name based on where you are on the screen next to me. So, Lucy, you're first, please.
Hi, I'm Lucy Davis. I'm the Chief Officer of Health Watch Sheffield, which is citizen voice around health and social care.
Thank you, Lucy. Emily?
Hi, I'm Emily Stanbrook-Shaw, Policy and Improvement Officer at Sheffield City Council, providing support to the committee.
Jane?
Councillor Jane Dunn, Southey Ward.
Steve?
Steve Harris, I'm Councillor in Graves Park Ward and also Deputy Chair of the Scrutiny Committee.
Vic?
Vic Bowden, Councillor for East Ecclesfield.
Gail, please.
Good afternoon, Councillor Gail Smith for Mosborough Ward.
Lewis?
Hello, I'm Councillor Lewis Dagnall, Labour Cooperative Councillor for Gleeds Valley Ward.
Martin?
Councillor Martin Phipps for City Ward.
Angela?
Angela Ardentia for Broomhill and Charleville.
Talib?
Councillor Talib Hussain for Boundary Ward.
Mike?
Councillor Mike Grabble, Richmond Ward.
Sam?
I'm Sam Martin. I'm Head of Commissioning for Vulnerable People at the Council.
Colette?
Hello, I'm Colette Harvey. I work for Sheffield Mind and I coordinate the Mental Health Partnership Network, which is a network of 50 charities and community groups across Sheffield.
Thank you, that'd be interesting to find out about. Mike Hunter, I was just looking, we have got two mics. Some meetings we have duplication, so I shall have to be careful. So Mike Hunter, please. Mike, I can't hear you, could you unmute, please? Still can't hear you. I think, yes, no. Shall I move on and then we'll come back, see if you can get your sound sorted. Gary?
Yeah, he's going to have to log off and log back on again. That usually works. My name is Councillor Gary Weatherall for Shire Green and Brightside Ward Chair.
Steve?
Afternoon, Steve Thomas. I'm a GP and Clinical Director at the Clinical Commissioning Group.
Sue?
Sue Alston, Councillor for Fulwood Ward.
Beverly?
Afternoon, my name is Beverly Murphy. I'm the Director of Nursing Professions and Operations at Sheffield Health and Social Care.
Heather?
I am Heather Burns, Assistant Director of Mental Health Transformation Programme, which I share with Sam Martin, and Head of Commission within the CCG Mental Health Commissioning team. And I'm appearing as myself now. I was Sam Martin a few minutes ago on the screen.
Share the job and the name.
Mike Hunter, do you want to try again?
Yeah, can you hear me now?
Yeah.
Hey!
That's attention-seeking behaviour, isn't it?
I'm a psychiatrist. My name's Mike Hunter. I'm Medical Director at Sheffield Health and Social Care.
Joanna?
Hi, good afternoon. My name's Joanna Rutter. I'm a Health Improvement Principal at Sheffield City Council in Public Health.
Thank you. And I'm Councillor Kate MacDonald, Councillor for Gleedless Valley and Chair of the Scrutiny Committee. Do we have any apologies for absence?
You've asked me to introduce myself.
Oh, sorry. So there's, sorry,
There might be no introduction. Adam Hurst, West Ecclesfield Ward.
oh, and Abdul as well. Oh, you've just appeared on my screen. I'm sorry.
Good
Abdul.
afternoon. Sorry, yes, my internet wasn't paying for it. Abdul Qayyum, councillor for Firth Park Ward.
I'm sorry, guys. It's just I've seen now we've got two. I've got two screens. I had slipped over onto the second screen, so apologies for that.
Don't think
oh, and I've got Eleanor. Eleanor, you're the same as Joanna Rutter, are you?
I am, but we're not related. But I am a consultant in public health.
Oh, I thought you were maybe using a different. Anyhow, so anyhow, I've got you all. Anyhow, good start. Anyhow, so welcome everybody. Do we have any apologies for absence, please?
Yes, Chair. Just one apology from Councillor Jackie Sater.
Thank you. We don't have any items on the agenda which require exclusion of the public or the press, do we? No. Any declarations of interest in items on the agenda? Lewis?
Well, it's a slight non-declaration, but I just for the record, as you'll know, where my wife, when she was councillor, was a member of was a governor of the Health and Social Care Trust, but she resigned in 2019. Okay. So I don't feel it's prejudicial having read the report.
No,
my taking part, but I thought I'd say it.
Thank you for mentioning that. Can I just say this is a.
Chair.
Sorry, you've got. Oh, sorry, Mike. Okay.
Yes,
Mike Drabble. Councillor Drabble.
Thank you, Chair. Yeah, just like to declare that I do work in mental health as a therapist. Part of the week that is in a GP surgery in the NHS.
Thank you. Make a note of that, those please, Jenny. And okay, thank you. I'm just going to say that this is our last meeting of the municipal year, so I'll say something a bit more about it at the end of the year. But we've worked really hard this year, and we're finishing today with our second mental health session of the year. I'm just going to quickly whip through the minutes of the previous meeting. First of all, can I take these as an accurate record of the meeting? Gary, is that a yes? Okay, thank you. No problems. Okay, silence is golden. I'm just going to go through them page at a time to see if there's any matters arising. Page 9 on your pack. Okay, and just on 4.1, we did have the meeting, and the outcome of that's on your on the agenda today. Page 10, page 11. Nobody can move, you see, because I'm page 12, 13, 14. Emily, under 6.9, did we can report that we have written to yeah, would you like to say oh
yeah, we've written the letter's gone, and we've received acknowledgement of the of receipt, but we haven't yet had a response, and as soon as we do, we'll circulate it.
Lewis, you wanted to say something?
Yeah, sorry. Once I figure out how to do it, it's the second bullet point, and I think from the way the minutes are written, the minute taker was slightly unsure and wanted confirmation, because the phrase is perverse incentives. That's correct. That's not misheard. And then the other point is that it's just the other way round on the. Many practices were achieving this target by prioritising it. They were prioritising non-urgent care to meet the target, and so because the commissioners have been more attractive to non-urgent care.
I mean, that was essentially that we did write the letter in those terms. So can we just note for the minutes that we've sent the letter, because we have already done that, so I don't think it's going to make any difference. Can I also note, just in passing, on 6.9e, that I think it's quite ironic, following the comment on fluoridation, that's the white paper on health service is going to take that power away from us, guys. So that's one of the ways in which local government powers will be constrained by the proposals in the white paper. Just like to comment on that and passing. Page 15, any matters arising? 16, 17. Okay, that's it. Thank you. Before we have got a couple of questions, but I'd just like to mention that I've had a request to switch around items 7 and 8 on the agenda, so we're just going to take those in a slightly different order. It's not going to make any difference to the meeting, but just for change, actually, just for a bit of fun, we decided to confuse everybody. Now, moving on to public questions and petitions. I've been notified of 2 sets of questions. Have we got anybody here to ask their questions?
We were expecting people to attend. Jay, have we got the questions in the waiting room?
Yeah, I've got two members of the public waiting to ask questions, a Neil Calderwood and a Jeremy Shaw.
Great, we could bring them in.
Yes, we can bring them in. Yes.
Would you like one in any particular order?
No, randomly.
Right.
You can see I'm, it's the last meeting here.
Councillor MacDonald, the members of the public is on the second screen.
Thank you. Oh, hello, George. You've joined us as well. Hello. I didn't realise you were coming. Hello, Jeremy. We've received some questions from you. They're quite extensive questions. Did you want to read them all out?
Well, thanks for allowing us to put these questions. Shall I just summarise? It's under heading. So
and then I'll say I'll mention how I'm planning to handle. Thank you.
Yeah. Okay. Well, thanks very much, Chair. There's the 4 groups of questions. First is on acute beds, because in the report you're given the ratio. Well, obviously a very good ratio for nurses per beds increasing, but we just wondered on the actual number of beds, has that increased? Because that was a query in the CQC report. How does the number of beds available compare with the national average in other cities? Are there enough beds to cope with expected future demand? And you also mentioned the closure of dormitories. We wonder whether that's solved the issue of sexual safety. On community services, the last reorganisation reduced the number of service centres and recoveries from 4 to 2. We wondered whether that's under review, whether that's going to be increased again, whether the trust is still employing directly art therapists, because we understand that service was cut over the last few years. And has the new service that you mentioned in August, is that preventing people hospitalisation of patients? On staffing, we asked a question in August about the Speak Up Guardian and whistleblowing that was mentioned in the CQC report, but we didn't get an answer to that. We wondered whether progress has been made on alerting staff to that. Have there been cuts in waiting times for other professionals like clinical psychologists? Are you anticipating trouble out of what we see as scandalous 1% pay offer for NHS workers in terms of staffing? And another key issue was the balance of experienced and inexperienced staff. Have the ratios improved there? Finally, in the future, you mentioned additional funding to deal with COVID. What's the actual level of that? When's a formal review going to begin of digital services, and how eventually will you measure the success of the Back to Good programme in its impact on the actual public, in terms of waiting times and accessibility and things? So sorry, it's a very long list. I tried to do a brief summary as much as I can.
Well, thank you for your questions, and thank you for coming today to answer them. Some of those questions I think may well come up during our discussion today. What I was going to suggest is if those questions aren't answered today, then I refer this list to the Health and Social Care Trust, because I can't answer those questions. They are questions really for the Health and Social Care Trust. So that they will be published though on the council's website together with the answers. Would you be happy with that as a response?
Yes, that'd be fine. Thanks very much.
And thank you once again for coming to taking the trouble actually to submit the questions and also coming to ask them. So thank you very much, and I'm sure you'll be watching. You may well be watching the rest of this meeting, so you may hear some of the questions. But we will send them to Health and Care Trust for a proper response.
Thank you.
Could you bring the next member of public in, please? And I'll try to whip back between the screens to find out where they're hiding. Hello, Neil. Hello, Neil. Welcome, and thank you for coming to attend this meeting and to ask your question. Well, go ahead and ask your question then, please.
So thank you for all of your time. My name's Neil. I'm a junior doctor based at the Northern General at the moment. I'm here on behalf of Medac Sheffield, which is a group of local healthcare workers who have come together and work on issues such as the one I'm going to bring up today. So what I'm hoping to ask and chat about, if possible, is a campaign called Vaccines for All. So it's with regard to the coronavirus vaccines that are coming out. And the campaign is aimed at ensuring that the vaccines are accessible to everyone, with particular regard to people that might not have documentation or ways of identifying themselves, or may find other barriers, such as fears around kind of data sharing with the Home Office or immigration forces and things like that. So my question is there's two parts to it really. One is it would be great if Sheffield City Council would be willing to sign up to the Vaccine for All campaign. Now I understand on that point that's not something that this committee can do. And I have contacted the council as I was advised by somebody that kindly, Emily, who replied to my emails. I haven't heard back yet. It's not been that long, so that's fair enough. But I thought it'd be great to have the opportunity to chat to you about it as well. Other councils have managed to sign up, so Oxford and I think Bristol and a few other places. So hopefully that would be something that Sheffield would be willing to do. And then the next part is really around facilitating a vaccine rollout that is as accessible as possible and does sort of address these barriers that unfortunately people are facing. The context of that is that though the government has said that the vaccine is available for everyone, we know that sort of on the ground and experience tells us that people are obviously apprehensive about it, and there's lots of reasons that people are hesitant. And I think that Sheffield, as well as lots of other places, has done great work to address those kind of concerns around perhaps the safety of the vaccine and things like that. So this is more of a conversation around the kind of practicalities around how the vaccine is rolled out and what we can do to ensure people are protected in these vulnerable communities are safe to come forward and ready to do so. Does that sound okay? I don't know if that's the right format to.
I wondered whether or not you might want just to say briefly what Vaccine for All is trying to achieve for the element, because I've seen your question and I've obviously clicked on the link. I just wondered for the other members of the committee, you might want to say what it's trying to achieve.
Yeah, thanks very much. So the campaign has been organised by a few different groups who are more generally trying to address universal healthcare access. So Patients Not Passports, MedAct, which works across the UK, and Migrants Organised. So the campaign has sort of emerged alongside wider work around ensuring universal access to healthcare, and its demands are to ensure that there is access to everyone, which the government has promised, But the issue is that with the principal issues are sort of registering for the vaccine, which sometimes involves ID. Now, again, the government has said that there's no mandate to say that you need to produce ID in order to get the vaccine. But in practicality, that is often the case, quite understandably, that services will, naturally ask for things like that. And then other aspects, the other main concern is the data sharing. So unfortunately, there is a relationship between the NHS and the Home Office, and data sharing has taken place over recent years, which has led to people's immigration status sort of being challenged, or ultimately to quite concerning outcomes such as sort of detention or deportation. Now, again, the data sharing on this front with regard to vaccines isn't quite clear at the moment, and certainly lots of people across the UK that are coming together and working on this campaign are trying to find out a bit more about how exactly it's working. But we know that at a local level there is room to arrange it in such a way that that can be protected to some extent. So, for example, in Liverpool, they're using paper records at the moment until they have a clearer picture of how data sharing is taking place. And where it's occurring through GPs, there's not such a well-formed sort of transfer of information between GPs and the Home Office. It's something that seems to occur maybe more on an individual basis on that front, which is reassuring. But as I say, sort of different places are taking steps to maybe mitigate that. So there's a few different aspects, but maybe those are the key points. But the website's really good as well.
Yes, we've just put it up on the chat. I just thought other members of the committee would be interested. So first and foremost, thank you again for coming to ask your question. Broadly, this committee has on a number of occasions, been very proactive in supporting tackling of health inequalities, and we specifically mentioned we didn't want to see health inequalities perpetuated in relation to vaccination programme. However, it's not up to the council really it's an NHS programme. So I can say that first of all, I'll raise the question that you've asked about whether or not the council will sign up. I'll raise it with the leader of the council. I'm quite sure, unless anybody on this committee's got an objection to me doing that, I can write to the leader of the council and with I'm assuming the agreement of the committee to sign up to this sort of broad approach towards ensuring that everybody has access to vaccinations. So that's the first thing I could do. Has anybody got a problem with that? I mean, we don't normally discuss questions, but since I'm going to be speaking on behalf of the committee, I would like to just ensure that nobody's got a problem with that. That we're okay. That all right? Okay. So we can do that. And I think actually though that some of the other questions that you're asking in terms of the implementation of the programme actually would fall more in the arena of the health service, because they're actually implementing vaccination. But I'll certainly draw it to the attention of the Director of Public Health, and with his agreement we can on behalf of Scrutiny just share your question and your comments with the health service. Is that okay?
Yeah, that's really kind. Thanks very much.
Yes.
In terms of,
I think you've got the sense that we are supportive, but there's a limit to what we can do, basically.
yeah, of course, I completely understand. If there is any other way that, I don't know if any of you have sort of seats at other tables where these arrangements are taking place, but of course we're very happy to sort of share our experience and share the lessons that we're learning from other places around the country. So I understand maybe this committee's role might not be directly involved, but if anyone else has got any, we'd be very happy to sort of help out and join in those discussions. I saw that somebody asked a question, I think, about our contact details.
Yes, yes.
So that would be Sheffield @medact. I think it's I should check this. I think it's .org.
Well, let Emily have it. Emily will circulate it to the to other members of the committee. And we've also had a comment in the chat that we've got several colleagues here from the CCG that they will share this conversation today with the chief nurse, who's the lead for vaccination programme within the CCG. So thank you for that, Heather and Steve. So they'll do that as well. Okay. Well,
Yeah.
Thank you very much for coming today and for asking your question. And yes.
Thank you very much.
Okay. Thank you for that. I just thought you'd be interested in terms of this organisation and on what they were trying to do, which is why I was more liberal than usual in terms of letting them address us. Now we're on to the first item on the agenda, which is the Health and Social Care Trust, the update. So when we did have a previous presentation from you, and this is the follow-up. So who would like to introduce that? Thank you for sending some material around. Are you going to show slides?
I'll introduce that if I may.
Mike Hunter, we can't hear you again. Something's gone wrong with your sound again.
I'm going to log off and log on again.
We can hear you, Mike.
We could hear you now.
It's a bit random, isn't it? Right, could I just ask if people can hear me now?
I can't hear anybody now.
Okay, I think.
All right, okay.
Can you hear me now?
I'm not sure I understand.
You're not, sorry, you're not sure. Sorry. Mike Hunter, was that you? Something's gone wrong with the sound. Okay. No.
Should I just crack on now and see if it works? Okay.
Yes, we can hear you now. Yeah.
Great.
My sound went funny. I don't know what's happening. Thank you for sending around some material. Are you going to do a presentation, or do you just want to introduce the information that you sent to us?
No, we sent some slides which show a sort of summary of the picture. We'll proceed on the assumption people have seen them. We won't present the slides as such, but my colleague Beverly Murphy, our chief nurse, and I will introduce this briefly in under 5 minutes and to leave most time for discussion and questions and so on, if that's okay.
Thank you.
Okay, so the last time we were with the committee was in August, and we said we'd come back in the new year to talk about further progress. The circumstances of being at the committee are well known, that Sheffield Health and Social Care received an inadequate rating from the Care Quality Commission following an inspection in February 2020, and we had a lot of improvement actions to get on with quickly. And we spoke last time about some of the improvement actions that we'd taken, and we welcomed the challenge from the committee to come back and to speak a bit more about the impact, the kind of so what question this meant for people that used our services. So I'm going to introduce that. I'll say a little bit about our inpatient services, our wards, and a bit about the developments in our community services. And then Beverly will pick up the mantle and talk a bit about our people and how things are for them more broadly. So in our inpatient wards now, because of what we've been able to do, what the team in Sheffield Health and Social Care has been able to do, which is described in the slides that we sent you, we know that there are a number of important impacts. Our service users are receiving better physical health care in the inpatient mental health setting than they were previously. And we know because we're asking all the wards every day and confirming that all the checks have been done as appropriate, confirming that people have been trained in the management of conditions like diabetes, in the management of complex situations like withdrawal from alcohol or street drugs, and a number of other things. So that stuff has been very widely got out there in the organisation. It's been really carefully monitored, and we know that people's physical health care now is better than it was 12 months ago. One thing that really directly impacts upon is smoking and smoking cessation, which, as you'll know, is one of the reasons why people with serious mental health problems, tragically, and you might say scandalously, are dying typically 20 years prematurely by comparison to people without those sorts of serious mental health problems, dying in their 60s instead of living longer lives into healthy older age. So smoking is an absolutely tremendously huge deal here. What we're finding now is that our smoke-free policy is being successfully implemented. Now, I don't say this with any hubris, and I want to stay grounded. We know there's still a way to go, but it is now very often the case that people come to our wards as smokers and leave our wards as vapers. And whatever you think about vaping, going from smoking to vaping is a tremendously positive step in the right direction, and can very often be the first stage into stopping using nicotine altogether. And that will make a difference in people's life expectancies. There was a worry that as we went more effectively smoke-free, because nicotine is addictive, that we might have a flare-up of incidents on the wards related to people wanting to get hold of cigarettes, and that hasn't happened. So that's been another really positive impact. Just switching emphasis, getting the staffing right, getting the training and the supervision of the staffing right has had a very obvious and material impact on falls in our older adult services. So fewer people are falling less often. And when we look at the information that we have at our trust board every month, you can see real positive progress in that respect. At the other end of the age spectrum, our safeguarding, including the safeguarding of children procedures, are much improved. We know that because when the Care Quality Commission came back in August of last year and then published a report in October of last year, they said that they observed that our staff's practice in relation to safeguarding had improved more or less across the board. Finally, in relation to our inpatient services and the impact, people that use our inpatient services are now having an experience with greater privacy and greater dignity because we've got rid of shared accommodation in dormitories. We know there's still more to do with our inpatient accommodation, like getting our seclusion rooms, for example, up to the standards of the Mental Health Act Code of Practice, and a number of other pieces of work. But that key piece about dignity and privacy and shared accommodation in dormitories has been done. And I'll just mention, because the questioner earlier on mentioned it, that 2 of our wards have now gone single sex. Switching from inpatients to community services, I just also want to slightly shift emphasis between CQC and the kind of best foot forward developments that we're doing, just to make the point that this isn't just about fixing the problems that the CQC identified, it's about planning optimistically with innovative services for the future. And I'm really pleased to say that our colleagues in Sheffield Health and Social Care, alongside colleagues in primary care and with Sheffield Mime, have successfully stood up a nationally leading primary care mental health service, even during the constraints and the challenges of the pandemic. So we have a situation now where psychologists and clinical associate psychologists employed by us are working alongside psychiatric nurses employed by Primary Care Sheffield and by workers who are called community connectors employed by Mind, in order to have a really highly integrated approach to getting specialist mental health care really embedded within 4 of our primary care networks, with a plan to scale that across the city within the next 2-3 years. So that's a great development, and they've seen 1,000 people even during the pandemic. So I say that just firstly to remind us that although it is our inpatient wards where these really serious problems have been identified, and we're absolutely serious about solving those, and the CQC report from October 2020 described how we were heading in the right direction almost everywhere they looked. It's also to remind people that the vast majority of mental health care goes on outside of hospital settings, and it's also really to set out our stall that whilst we absolutely have to address these shortcomings that the CQC identified, we are also absolutely looking forward in that best foot forward sense with optimism to putting together really new and innovative services for the benefit of the people of Sheffield. So I think I've gone on a bit too long there, but I'll hand over to my colleague Beverly.
So I want to make a few comments about the impact that the improvements have had for our staff, and also what we understand our performance to be on a day-to-day basis. We have really improved the inpatient ward leadership and support for less experienced staff. We've actually filled across our acute wards all of our ward manager and deputy ward manager roles. Now that's quite significant, given that we have more deputy ward manager posts than most mental health trusts in the country. And in fact, we're rated highest in the country for our ratio of registered nurses per 10 acute beds. So we're really confident now that actually more junior nurses are getting the leadership that is required. It doesn't, however, mean that everything's absolutely perfect, because of course some of our more junior staff have, with the right support and development, now stepped up into more senior roles. So although we filled some of those roles, we have got more of a vacancy factor of the junior part of our establishments. In fact, we've got all of the nurses that are due to register in April who are in training with us. They are due to take up jobs with us. So even before people have got their registration now, we're managing to support people through to employment, which is fantastic news for the continuity of services. What that leads to, of course, is that we've got better and more skilled resource and more consistent resource to ensure that people have improved supervision on a day-to-day basis. And we've got really robust data internally that demonstrates the fact that people are getting supervision. And part of our improvement plan was actually being more ambitious in the number of supervision sessions that any one member of staff could expect to receive in a year. So we've doubled the amount of supervision that people get, and we are now increasingly at 75 to 80% compliance with the standards on an ongoing basis. So that's really, really positive news. And that view was actually supported by one of our nurses who attended the quality board with our regional chief nurse back in February, I think it was, February or early March. And she actually talked about her experience to our regional chief nurse, our commissioners, our regulators, and reflected that actually there is more support available and junior staff are being supervised more consistently. So that's something about what's changed for our staff. For our performance, I will say that our integrated performance and quality report, which can be found as part of our public board pack on a monthly basis, demonstrates that length of stay, although it had been creeping up, has now started to reduce again. And we've put a recovery plan into place for the numbers of people who were needed to be cared for out of city because we didn't have beds available. And we're seeing that recovery plan is having an impact because the length of stay is actually coming to within the target that we set for ourselves. There were questions asked about the numbers of beds that we have. Actually, we do have a low bed base when we look at the benchmark nationally. And historically, there has been service changes, which has meant that we have taken a small number of beds, that is 6 beds, out of our bed stock. But what we have also done is we've introduced step-down beds, and we're about to introduce more step-down beds. And we've also introduced the decisions unit. The decisions unit was compromised during the COVID period. So we're running at a 4-day-a-week service at the moment than 7-day-a-week. But in ordinary circumstances, as we've reduced our acute beds, we've actually increased the opportunities for the people of Sheffield to have choices about where they receive their care according to their individual needs. We do have further temporary bed closures to make, but those are temporary closures based on our need to improve our inpatient estate. Our inpatient estate is for acute care is currently compromised at best and not fit for purpose at worst. Those risks and compromises are well known. We do have plans to improve our inpatient services, but the committee will be aware that to do estates changes in a live clinical environment presents some risks. So over this next period, this calendar year, in fact, all of our acute inpatient units will see significant improvements. I've said that we have reduced our length of stay, and what that's meant is that people are now less likely to receive care away from Sheffield or out of area, as it commonly gets called. So from summer 2020, we were becoming increasingly reliant on beds purchased out of area. With the improvement plan that I've already mentioned and the corresponding reductions in length of stay, we are addressing the numbers of people who are out of area. We did have some challenges to the improvements over the winter months because we had both of our older adults inpatient wards closed because of COVID outbreaks, and sadly and coincidentally at the same time our older adults home treatment team that is part of the offer to try and care for people at home, they also had an outbreak, and we had to stand colleagues down and isolate away from a clinical care. So we're dealing with that at the moment, and we will get our recovery plan back on track within a matter of weeks. We've also implemented a floor to board review of performance, and you would have seen from the original report into the organisation that we had compromises. We were actually rated inadequate for well led. It's too early to speak to the impact of our floor to board review of performance, but the aim is that as an organisation we know where our risks are, and our local teams are engaged in solving issues and mitigating risks with the support of the executive and the operational leadership teams. So just quite quickly then, does this mean that everything is completely on track at Sheffield Health and Social Care? Well, of course, we still have risks, and we continue to mitigate and manage those risks. And a few things to note. So I have already noted that some of our inpatient environments do require significant improvement. We also know that we've got digital systems that require updating and replacing. And again, we have a programme, and whilst that programme is implemented, we have mitigations in place. We know that in some parts of our services, there are issues of access, and we are running with waiting lists. And again, we have recovery plans for all of those waiting lists that have been, those recovery plans have been received and scrutinised by our quality committee and also our board of directors. Despite the fact that we've had phenomenal success in recruiting more staff, we also know that we have some hotspots of short staffing. So we know that one of our recovery teams in the community, we had a pocket of turnover of staff, and you will appreciate that from staff leaving to recruiting and having new staff in post, there's usually a lag of time, and we do have a hotspot in one of our recovery teams. And of course, it would be amiss not to mention that we are delivering all of the improvements during a global pandemic, and we do need to anticipate the future demands for services. And I'm quite certain that our commissioning colleagues will be doing some work around anticipating demand. And as a care trust, we are working with NHS England to model what the future demand might look like, so that we can accordingly flex our services. So happy to leave it there, Chair.
On mute. Thank you very much. Both of you for that. Can anybody else hear an echo? I'm hearing an echo of my own voice. Oh, okay. That seems to have been, I think that's been sorted now.
Stop now.
Yeah. I'm going to ask for, I've got a couple of people wanting to come in. Can I just ask you, before we go on, what the formal position is with the CQC now, please? Either Beverly or Mike Hunter.
So we remain rated as we were. So we were re-inspected in August 2020. As Mike said, the report was published in October 2020. The report listed very clearly significant improvements that matched our own assessment. But at that time, in part because of COVID, and in part because they were coming to inspect only the warning notice, they didn't re-rate services at that time. There was never an intention to re-rate services. However, they were content and comfortable, in fact, to let the Section 29A warning notice lapse on the basis of the evidence they found of improvements.
Thank you for that. I just thought that the committee would want to know that. I've got two people have indicated. I've got Sue Alston and then Martin Phipps. Anybody else? I'm going to leap over Lucy Davis and Mike Drabble. Okay. Well, I'll ask you again if people want to give you another opportunity. But first of all, Sue Alston, please.
Thank you, and thank you for coming back with your update. And you know, I'm sure we're all pleased to hear that things are moving in the right direction. Can I just ask, during all this sort of change that you've had, how this is impacting on the sort of longer term patients? In particular, I'm thinking about continuity of care, because you know, both for medical care and nursing care, how are patients actually being treated in terms of having consistency of who they see and who is taking, you know, looking after them in terms of planning their care? Thanks.
Thank you. Who'd like to?
It's perhaps I'll make a start and Mike might follow up. It's an interesting question. So I would say that COVID in particular has raised us challenges in this regard, because you will appreciate that we've had a number of colleagues, over 100 at some points, who've been away from work either because they've tested positive for COVID, or perhaps they were shielding, and it might be that because of their role in the organisation it was difficult for them to fulfil their clinical commitments. Some people who have shielded from time to time have continued to fulfil their clinical commitments if they worked in the community, and the service users that they worked with, it was appropriate and safe to use technology in order to facilitate those that continuity of care. But it hasn't been possible in all cases. So in those instances, we have assessed our service users. We've looked to see whether they've had specific needs because of the change in care coordination, mostly we're talking about actually. And we've held caseloads as teams, zoned as to whether or not people need to be seen regularly and routinely, whether or not people can be seen less frequently and by different people, and whether or not people can be in what's called a watching and waiting group. So really what we've done is we have tailored the clinical intervention to the individual patient needs. So I'm certain, Councillor, there will have been some disruption, but what I would say is that we have taken a patient-centred approach to use the resources that we've got to match the individual patient need.
Can I just add in, if I'm not muted, I was talking a minute ago about acute inpatient wards as well, and because you raised long-term patients, I just want to mention long-term or longer-term rehabilitation inpatient care, because we have wards doing that as well, which are based at Forest Close at Middlewood Road in the Uterbridge direction. Those wards are rated as good by the CQC, and that rehab team won the positive practice in mental health rehab team of the year award the year before last. And I say that not to kind of distract from any of the difficulties, but to just help provide a balanced view of how mental health services in Sheffield are across the board. We know where we're really challenged, and that's mainly on our acute inpatient wards. But we know, and I'd say it because you mentioned long-term care, that the longer-term inpatient wards, the rehabilitation wards, are in good shape.
Thank you for that. Sue, are you happy with that response? Okay, that's great. Thank you. I've got Martin Phipps now, Councillor Martin Phipps.
Thanks, Chair. Thanks for coming and for the presentation or talking for it. I'm just wondering, step-down beds were mentioned. And I was just wondering, if you were going to make use of the step-down beds, then would that basically require some kind of multiple beds per room scenario for patients, a bit like the dormitories that are trying to be eradicated?
We have refurbished, or rather we're in the process of refurbishing one of our buildings with 10 single bedrooms with en-suites. That will give people a standard of accommodation when they're in distress that looks after their privacy and dignity, and where clinically appropriate, avoids them going into an NHS acute hospital bed. And we want to work with the third sector to manage that service, because we want to work with recovery and destigmatisation and working in different ways. So really increasing those choice in those options, but they are single bedrooms with ensuite facilities.
And committee members will have seen that the white paper on reform of the Mental Health Act is out for consultation until the end of, or more or less the end of April. And that principle about privacy and dignity in single rooms and ensuite accommodation is very much contained within the white paper. So if people are commenting on the white paper, that's helpful to bear in mind.
Thank you. Martin, are you happy with that? Sounds like a response you'd like to hear. Anything else? Did you want to come back?
No, that's great. Thank you.
That's great. Thank you. Yeah. Lucy Davis, would you like to ask your question or questions, please?
Yeah, thank you, Kate. So I've got two questions actually. So with the first one, I just want to pick up on something that Beverly, you just mentioned, and it related to tailoring clinical interventions to meet individual patient need. One of the themes that we have come to us at Healthwatch, and something that featured in one of our recent reports, was about how actually services sometimes weren't able to flex and be tailored to meet sort of certain needs. And I'm aware that there's also been feedback via community partners, our voluntary sector partners, around certain groups that have found it particularly difficult to access the right support for them. So for example, people with autism, people from the Black community who haven't necessarily been able to access support which feels appropriate for them and which meets their needs. So the first question relates to kind of what the recognition is of that and what plans there might be in place to address services for particular groups. My second question relates to a shift in the delivery model. So the changes that have taken place around how appointments happen, and obviously COVID has meant that many appointments have had to take place over the phone or on by virtual means. On page 40 of the report, in the section that is labelled changes made during the pandemic, there's a sentence that says, IAPT are currently undertaking a piece of work to better understand the demographics of people accessing their services, but do not believe that there have been any untoward negative impact on access from the changes to delivery. Kind of conflicts a bit with what then comes later on, where there's reference to actually possible ways in which that could exclude people, and it certainly conflicts a bit with what we've heard in terms of that being a mixed bag for people. For some people, great, it really works, for others it doesn't. So I'm just wondering what the plans are to explore that more, so that whatever sort of changes are set for the medium or long term, we know that it's a change that is going to work for people.
Two really good questions, thank you. I mean, I think that the first thing is, I'd say that I'm keen, I'm relatively new to Sheffield, and I'm really keen, Lucy, that we work much more closely with Healthwatch. And so what the communities are telling you, because they've opted to come to Healthwatch, we're actually taking that learning and we're doing something about it. So that's the first thing I'd say. The second thing about care and meeting a whole range of people's needs, and particularly thinking about vulnerable people who might be excluded. We actually had a conversation at board today, and it's not the first conversation. I was assuring our board that we are ensuring that we are collecting equality data routinely across a range of issues. And the two issues that I think are the biggest priorities, the people who are accessing our service and the people that are subject to restrictive interventions. And that might be being detained into services, it might be being restrained, injected, secluded, and so on. We need to understand how we are serving the communities, or in fact not serving them. And I don't think that we've currently got a data set that convincingly assure our board of directors, or in fact this committee, that we don't have access issues. So we are addressing that, Lucy, and I'd be quite keen to have a conversation with you in a different setting about the things that you're seeing. Regarding the delivery model, I think there's a host of issues there, and again today an evaluation report was presented to our board of directors, looking at not only how staff have experienced the change in the way that we offer services, but also our service users. And you're absolutely right, it's a mixed bag. I think that we need to take the learning from the pandemic and make sure that we've got the right technical ability to provide care to people technically when that's clinically appropriate, and personally that's somebody's preference. And I think we really need to make sure that as a care trust we don't fall back on what our preference is, both as an organisation and individual clinicians within the organisation, because actually some of our clinicians are keen as mustard to get back to face-to-face treatment, because that's the way that they've always worked, perhaps, and that's their preference. We do need to fully understand at the point of assessment what somebody's preference, personal preferences, a patient's personal preferences, rather than the clinician's personal preference, and making sure that we've got the range of fit to flex. So I'm at risk of just repeating what you've said yourself, Lucy, but I think at the moment we're at a point of having information, but we need to now use that and develop our service offer from that.
And can I add in, Lucy, if I may? Of course, and this isn't something that Sheffield Health and Social Care can address on its own. I think it's for all of us. One group that is particularly often digitally poor and digitally excluded are groups of asylum seekers. And I think there's something about us, taking pride in our history as a city of sanctuary, and bearing in mind that, the terrible trauma that asylum seekers have very often experienced on their way, and the impact that has on their mental health. And it's really important that I think we think as a whole system in Sheffield about how we make that link with what could be a digitally excluded but really vulnerable group.
Okay, Heather's indicated that she'd like to come in on this point. Well, in response to the question, anyway.
Yes, thank you, Chair. Just really to sort of reinforce what Beverly was saying, aside to the work that the report that's gone to Sheffield Health and Social Care Trust Board today about digital inclusion, the Sheffield Psychology Board partners, which includes voluntary sector organisations, the Children's Hospital, the Teaching Hospital, all partners working in that psychological wellbeing space, have agreed that they would like to do a review across all services from the perception about clinicians saying they have concerns about whether the digital offer is suitable in all cases, particularly Children's Hospital colleagues, psychologists talking about how they're trying to assess risk when they fear that there's an adult in the same room when they're trying to do a therapy session with children. So there isn't the intention that the Psychology Board across the whole city will look at the impact of digital offer and come up with some kind of sort of risk assessment or process that will help people identify when it is and isn't suitable. And that does connect to the work that SHSC are doing themselves, but their own staff will be helping with that piece of work too in the Psychology Board.
Thank you, Heather. Lucy, did you want to come back on any of that?
Yeah, no, thank you. I'm glad to hear that it's all on the radar. I don't know if this is appropriate, but I'm conscious that some of what I bought is stuff that's come through our VCS colleagues, and I don't know, Colette, if there's anything you wanted to add about the experience that VCS organisations are having, particularly in relation to the point about specific groups of people that are maybe not getting the service they need.
Thanks, Lucy. Yeah, so it was last summer I worked with Public Health on the Mental Health Rapid Impact Assessment, and I gathered data from across the 50 organisations that are involved in the Mental Health Partnership Network, which I coordinate. And so that data was gathered and it's put in the report, which I think is the next agenda item for this meeting. So I don't know if you've had a chance to read through the data from that report, because within that report it details a number of different groups, different people from across the communities of Sheffield who do feel excluded from mental health services and support. So Beverly might happily have a conversation with you about the data that's been included in that report. Prior to this committee, I also reached out again to voluntary sector colleagues, my peers from across the many different networks that exist within Sheffield, and have updated that and filled some of the gaps in the data that we gathered last year. So, for example, I've reached out to the adult autism project, which is just starting up, and gathered some further data around their experiences of accessing mental health services. So there are a number of organisations who have got that kind of reach out into the communities, which it sounds as though they don't necessarily always feel included in the services that have been provided.
Thanks, Claire. And can I just say as well, as the statutory specialist mental health provider, we absolutely appreciate that this has been a torrid time. It's been a torrid time for lots of people, but this has been a torrid time for the VCS as well, for all sorts of reasons. And that in looking to the future, it's really important, I think, that specialist providers are really supportive of VCS colleagues and their sustainability, because us working together is the key to cracking this.
Thank you for that. I mean, it's obvious that there are two different dimensions, and I'm pleased to hear that there's going to be some sort of review of the suitability of services actually to be taken online, but also, as Lucy was suggesting, in every one of our committee's meetings, I think, during COVID, that the issue about the digital divide has come up, and that's about accessing those services as well. It is dealt with in the other report, but there are two elements to it, and the council's certainly doing quite a lot at the moment in terms of trying to address the second of those. So, Lucy, are you okay with those answers then?
Yes, thank you.
Yeah, that's good, and thank you for the answers. Is there anybody else that wanted to? Oh, Mike Drabble, that's right. I'm only saying your name because we've got two mics. So, Councillor Mike Drabble, please.
Thank you, Chair. And thanks to all of you for coming and presenting to us today. I know we appreciate it. To prepare for this meeting, I talked to some GPs and practice managers I'm acquainted with, and two main things stuck out. One's a positive, actually, in that those surgeries that had an attached CPN really do seem to get a lot out of and value that service. So just wanted to pass that along and say, if anything can be done to kind of, safeguard and even enhance that programme, and know it'll be appreciated, because I think it is really valued, actually. The second point isn't so positive, and it's kind of a follow-up to Lucy's point about IAPT. And I think there's still a perception out there, rightly or wrongly, that IAPT is almost a Goldilocks service, in that it seems to only take those patients whom it's likely to have kind of a relatively simple job to help. And some of the GPs do still think that they are left with more the challenging clients who could actually, kind of benefit from that service. So I'd just like to ask, is there anything can be done to maybe help dispel that, or actually kind of maybe improve the IAPT service so it is more inclusive than some GPs and practice managers perceive? Thank you.
So I think
who would like to have a go at that? Mike Hunter? Yep.
Yeah, I think Councillor, in a way, your two questions are related, because the first part about how we're getting specialist staff into primary care, which is, I agree with you, all the feedback I hear is positive as well. That is the solution to the second part of your question, which you've described as the Goldilocks problem. I probably can't use that phrase to describe it. What I will say is that IAPT, it's a very specifically designed service for people with a particular type of difficulties, with very particular outcome measures, and it's a nationally specified service. That's the other thing that's relevant. I appreciate that can land for some people as being limiting, and that's why we really need to get the primary care mental health thing scaled now, and at significant pace. But there's a good opportunity to do that. We're one of the 12 early implementer sites in England. We're one of less than a handful really that has cracked on and been able to do this successfully during the pandemic. There's great enthusiasm amongst the clinical directors and the primary care networks to work collectively on this, and to think about how we might align resources that have traditionally been in primary care, resources that have been traditionally in secondary care, bring them together, get them much closer to people's communities and families and so on, and fill that space that you're describing. Because yes, we recognise that. I'll stick my neck out and say, the way that traditionally primary and secondary care mental health services have been constituted and designed has sometimes not worked for the best interests of the people who need to use those services because of the gaps that can arise between them. And we're absolutely determined to work in this collaborative way in the primary care space in order to fill that gap.
Thank you for that. I can see that Heather's got her, have you got your hand up, Heather, or are you taking it down? Oh, you're taking it down.
Well, it was just to sort of say Mike's covered most of what I would say, but just to be very specific about the extension to the primary care mental health service, there are something called additional role reimbursement opportunities for GPs. What we're trying to do at the moment is work with GP practices so that we don't have 1,000 flowers blooming. Because I think Mike Drabble, Councillor Drabble, what you were referring to is some GPs have used internal money to appoint their own. What we feel that in terms of an overarching approach and a strategic approach to mental health delivery in the city is that we don't want practices, if you like, to have their own, because then what about supervision? How do they connect to teams? So I think the key to that is these additional role reimbursement opportunities that practices have, but how we actually work with them around the rollout of the primary care mental health service, that new service that was put in place last August, and to sort of extend it across the city so that we've got a bit of a coherency. What we're finding, and coming back to the member of the public's question earlier, what we're finding with the primary care mental health service, it is so much closer to primary care. They are picking up that difference between IAPT and what a primary care offer would be, and also what the secondary care offer would be for the Sheffield Health and Social Care Trust. And actually this is where, if you like, the future of mental health services is moving into that space. And what we need to do is make sure that we're investing in the right roles in the right places, but in a very good and connected way.
Thank you both.
I'm sure you'll be, are you reassured by that response, Mike Drabble?
Yeah, thank you. You know, look, we understand this isn't kind of a perfect situation. There's lots of work to do, but yeah, I am satisfied with the responses. Thank you.
I think those of us as councillors who see a lot of issues on the ground as well, you know, would really very much welcome strengthening that gap where, as well, where there's much more of a continuum between primary care based services and the secondary care ones. So that's great, thank you. Any further questions before I thank our contributors and move on to the next related item? I'll just whip over to my second page. No, I don't think so. Can I just thank, well, all three of you. I know you'll still be, I assume you're going to be here for the next item as well, Heather, but certainly from the Health and Social Care Trust, well done for the improvements that you're making. Obviously, you're not there yet, and we'll probably want to talk to you again. Well, not us personally, but Scrutiny will probably want to have another conversation with you in due course next year. But thank you for coming, thank you for your contribution, and thank you for the improvements that you've been making for the people of Sheffield.
Thank you for asking us to come along.
Thank you. Moving on seamlessly to the next item on our agenda, and thank you very much for a comprehensive background material. I really feel as though I've done my homework today, so thank you for that. And I hope everybody else has done their homework as well. Who would like to introduce the report?
So I'm quite happy, Chair, to introduce the item.
Okay, thank you very much. Is that you, Sam? Yes.
It is, yes. Up in the corner or somewhere buried on the other side of your screen.
Yeah, I'm sorry.
Okay,
I'm still jumping between two screens, and people are moving on them. So I think today it's my it's a torment, isn't it? So Zoom. So thank you, Sam. Off you go, please.
Okay, thank you. And so yes, you're right, Chair. That so you've had a very comprehensive and long report, which you'll probably have guessed we didn't write specially for the Scrutiny Committee meeting today. So I'm sorry to kind of have to say that. So when we came, and I think most of us who were here today were at the August Scrutiny Committee meeting as well. So, and when we came in August, we were talking at that point about what we knew at that point about the impact of COVID on mental health of the city. And at that point, there was a lot of things unknown. There were lots of things emerging. There were lots of issues that we were in the middle of that immediate pandemic response pretty much, although the kind of immediate issue in terms of hospitals sort of tailed off a little bit. Since then, you will be aware that the Health and Wellbeing Board had commissioned a whole range of rapid impact assessment reports about the impact of COVID on a whole range of things across the city: economic development, cultural issues, disabilities, and mental health was one of those themes. So by the time we were preparing to come back this time, we knew we had that report that had a wealth of data in it, which had taken a lot of effort and a lot of time by people to pull together. So although I was conscious that you may already have seen some of that information, because I think the Health and Wellbeing Board have published those reports, it runs to hundreds of pages, and what I was conscious of is you may not have had the time or the opportunity to actually read the mental health one. So rather than try and produce a kind of alternative set of data, what we felt was that the rapid impact assessment report was the best way of presenting all that wealth of information to you, give you the chance to have a really good sort of chew over of that, and I guess ask some of us, because a lot of us were involved in pulling that data together. As Colette was saying, some of the data in that original report came from consultation with VCF and communities way back in sort of August, September. So what we are conscious of is that report was done at the sort of back end of last year. So obviously we're now into March. So things, and obviously with the pandemic, like things are moving very quickly. So it may be, and I think there probably are some opportunities today for, like you've had a little bit of an update from the Care Trust colleagues today about what might be a bit more current than was in the autumn, and similarly in terms of GP responses and feedback from the VCF, there might be a little bit more of an update that's a bit more live that we can give you today if you're interested in some of those areas. I guess the other thing, what we've tried to do with the report is present you the report, but obviously the original rapid impact assessment had a number of recommendations. So what we have tried to do is give you a kind of short update at the sort of start of the report about our current response to those recommendations, because we're not just standing still as a system. We are trying to sort of think about how can we address some of those and move on some of those recommendations so that we can kind of get some stuff done. So there are, and connecting these issues together, Chair, things like, so in the recommendations was a recommendation about growing sort of primary care response and connecting up secondary and primary care. And you've had exactly that conversation just now from colleagues at the Care Trust and Heather around the primary care mental health programme, which I should add that we are, as commissioners and a system, we've been nagging NHS England to get on with the rollout of that programme faster than is set out in the long-term plan. And I think I'm going to look to colleagues a little bit, but I'm crossing my fingers that we think that we are able to do that much more quickly. So over the next year, rolling out that programme where it would have originally been taking 2, 3, 4 years. So that's because we're doing a good job at it. Mike's talked a little bit about the kind of positive aspects of it, but we're doing a good job and we're seen as delivering. So I think that's a really good opportunity for Sheffield. So I shall pause there because obviously the report's huge, so I won't talk through it in lots of detail. You'll probably ask me questions about what's on page 54, and I'll think, gosh, I don't know what's on that page, and I'll have to get it on my screen. But I think probably the sensible thing to do is open it up for questions.
So did anybody else want to say anything? I was just wondering, particularly Colette, you might want to sort of say a bit about this new mental health partnership thingy.
Thanks, Kate. I have actually written some information down because, like I said a moment ago, I did do a call out to the organisations in the network as to whether or not there was further updates on the information which was gathered last year. I actually ended up getting a lot of information back from the organisations in the network. So I'll try and provide like a really brief update now, and then I could share more information with this group at a later date, which is like in a more of a written format. So I could take a few minutes now. Would that be okay, just to provide a bit of an update?
Yes, I'm quite keen for an update because a lot of the stuff that was done before was really, it's missed this whole lockdown, and I'm quite sure the impact of it is not a simple one. I think it's going to have a complex impact on what the situation was earlier last in 2020. So yes, Colette, please take a few minutes.
Thank you. So it might be helpful if I explain a little bit more about my role and about the network.
Yes,
So I'm based at Sheffield Mind, but I don't represent Sheffield Mind. I coordinate a network of 50 community groups and organisations that provide mental health services and support across Sheffield. And there's a real mix of different organisations within that network. And I'm sure you may have heard of like other voluntary sector networks that exist across the city as well. So this is just one network in kind of a complex system of different networks that exist across the city. What's unique about this particular network is its focus in on mental health. And what I tried to do is link in with other networks so that the information around mental health is kind of cascaded out across the different networks within the city. So I'm not directly responsible for the delivery of any of those services within the network. I just coordinate kind of information exchange and opportunities for collaboration across the network, and then also linking into the health system as well. So last summer there was the mental health rapid impact assessment. We gathered a lot of data from across the network around what the impact was of the pandemic and lockdown at that point. And then Sam asked me if I could get an update from the network for this particular meeting as well. So I've got a brief update around community needs and service demands, and then also some examples of the kind of innovative community work which has been happening across the voluntary sector. So I don't know if you've had a chance to read through the kind of the full report and look at the data which came from the network last year, but overall the feedback from the network was that data and community intelligence still stands true. But what has happened now as the pandemic has continued, the situation for many people has worsened and people's futures remain quite unsteady and uncertain. So people's lives have become more complex and people are experiencing a higher level of mental health distress. So I've received feedback from across different community groups and organisations that they're dealing with more complex cases. There's people who are already experiencing disadvantage in their lives and now experiencing further difficulties. And these difficulties may relate to housing, employment, relationships, finances, and this has had a detrimental impact on their mental health. There's a climate of financial uncertainty, lack of guarantees around rented housing, and a range of different cliff edges that will be created when some of the COVID protections are lifted. So there's a lot of nervousness around that kind of roadmap out of COVID and what that means for people in their lives. There's also the hidden impact of long COVID. So from across the voluntary sector, the work that they're doing in the communities has been extraordinarily responsive and agile and adapting to community needs, but many of the community organisations are quite overstretched, resources are overstretched. So there is a need for investment in mental health services beyond that of statutory services and supporting people in the communities, in their homes, where they have that kind of structured social support that they can access as well. So I think Lucy mentioned that there were a number of different groups in particular that kind of their needs kind of came out of this rapid impact assessment. So I'll talk you through some of the data which came kind of out of the survey last year and then update it with the information from this year. So as I'm sure you're aware, the pandemic and lockdown has hugely impacted on people's mental health. There's social isolation, increased levels of depression, stress and anxiety, and that's led to the exacerbation of existing mental health conditions, as well as leading to people experiencing mental health distress for the first time. There's a need for a greater level of preventative community-based support to enable people to manage their mental health and stay well in their community. And there's certain communities that have been disproportionately impacted by COVID, in particular people from Black, Asian and minority ethnic communities from across Sheffield. And people are really calling out for culturally competent and accessible mental health services. There are other groups and communities who have also been heavily impacted. And there's a kind of calling out for investment in services relating to children and young people, carers and young carers, people who are experiencing severe mental health distress, older people, people who want to access counselling but having difficulty accessing kind of longer term counselling, people whose lives are complex or who are experiencing complex mental health needs, people who've experienced trauma either during or prior to the pandemic, people who've been bereaved, people who are experiencing digital exclusion. And as we were talking about before, digital exclusion isn't just about whether people can access technology, it's about whether or not that service kind of meets their needs and they feel able to engage with services digitally. And then this year, we've gathered some data which demonstrate there's particular needs around adults with autism being able to access mental health services, women who have been disproportionately impacted by COVID, and people who've been very isolated over the past year, who are increasingly anxious about that roadmap out of COVID and what it will mean to socialise and get public transport and things like that, going out and meeting people again. Yeah, and then there's a lot more information and data that I have that kind of provides much more nuance around those different community groups and their experiences of the pandemic and the types of services and support that they're looking for. So I can share that report and kind of more of that information with the group later on.
Thank you, Colette. If you want to share that with Emily, then Emily will circulate it to the members of the committee. But thank you for that. And I don't know how long you've been in post, but we haven't met before, so nice to meet you as well. Questions and comments? Was that you, Adam? Were you waving your hand there?
Yeah.
Councillor Adam, off you go.
Yes, okay. Yeah, I was very interested in what you're saying, particularly about, I was going to ask you about the gender issues before you mentioned them. But because I know there is a report out today saying that although men are more likely to die from COVID, particularly older men, women are actually more likely to suffer from the effects of long COVID and are certainly having a tougher time of it mentally. I actually sometimes wonder with things like that is, are women just admitting that they're not coping and men being typical men? I might be being sexist there, I apologise. But I did want to maybe ask, just for your views generally, in terms of there are still gender differences in health and also in how we actually perceive our own health. And I was wondering if there's anything that you're doing to really look into that, because I think particularly with long COVID and the longer term effects of people and the associated anxiety and stress, what the long-term implications might be and how we do actually look after both women's and men's health in the light of that. Thank you, Chair.
So who would like to start with that one?
I could come in, Chair.
Thank you, Heather. You were on my other screen. You're at one end and everybody else is on the other end. I've got you now. Thank you.
Just to sort of pick up on the point about long COVID in particular. So as part of the work that Sheffield Psychology Board have been doing with teaching hospital psychologists and also frontline clinicians, there's been specifically work done to look at people that have been discharged from the intensive care unit and to give follow-up to them to check around the psychological health and well-being, because that was noted in early days in terms of the concerns of the psychologists and counsellors working in that space. Now, what we can do, and Colette is on that board alongside myself and Steve and other colleagues, we can actually ask them around any sort of gender trends or traits that are coming through. And I think probably we need to be thinking about some of the questions that actually Colette's raised around specific groups in terms of what is being targeted. I know, for example, IAPT have been doing some specific outreach work in different community languages. We've met recently to talk to them about the deaf community and their experience of mental health problems. So there are sorts of groups that we're trying to drill down into, but clearly there's more groups that we need to look at.
Joanna, you wanted to come in on this point, or this question?
Yeah, thank you, Councillor McDonough. I think I just wanted to add to what the previous councillor was just saying about the disproportionate impact, particularly on women. And I just wanted to expand on that a little bit, because I think it's not just the kind of impact of COVID, the disease. I think what we're starting to see now is increasing evidence of the disproportionate burden on women of the socioeconomic impacts from COVID as well. So women have disproportionately lost jobs over this period of time. They've shouldered the increased burden of caring both for children and for older relatives, things like that, or being isolated from providing care as well from people who they would have been caring for previously, visiting care homes and things like that. So I think it's just really important that we kind of acknowledge that as well, you know, and certainly, I mean, I take a lead for suicide prevention for the city as well, and this disproportionate impact on women is something that's quite concerning to me as well, because a lot of the socioeconomic impacts of COVID are the very things that can drive suicide rates in the future. So, you know, loneliness, isolation, unemployment, you know, poverty, or, you know, relationship breakdown, all of those kinds of issues. So thank you for that. I just wanted to expand on that point a little.
Thank you, Joanna. Mike Hunter, did you want to come in on this question?
Yeah, I just wanted to say, as a medical doctor by training and in my practice, I really believe it's important that we talk about intersectionality in terms of planning here, and just developing on what was said. Whenever strain is applied to a system where intersectionality is a thing, then the people who sit at the disadvantaged ends of the various dimensions of intersectionality suffer more, and that strain can be all sorts of things. In this case, we're talking about the strain of COVID and how that's landing on women and BAME groups and so on. But it could also be the strain of economic recession. It could also be the strain of climate change. And I think it's really important to get that concept in there about intersectionality and then the strains in the system within which it exists.
Thank you for that. So anybody else want to ask a question? Councillor Jane Dunn.
Thank you. It's quite a practical question. I'd like to know what plans we have as coming out of lockdown. You mentioned it, I think your name is Colette, about people that have been on their own for over 12 months and they may not have any health problems, or even the anxiety that they will be getting about having to go back out into the big wide world. What are we doing as a city in order to actually help employers and give advice, and just so we can support people as they come out? I am extremely worried about women. I mean, a lot of the women's jobs are highly at risk, and I don't even know whether they'll be viable. So the stress that will be for everybody to come out and pick up life as normal, but they can't cope. How do they get the help? So it's actually in the workplace and everywhere else. What messages are we sending out just to help everybody come back to normal? Because it isn't going to be easy. The conversations I've been having, people have almost become, somebody said to me, I feel institutionalized at home. And I can understand how she feels like that. So I want to know what plans we've got to help support people come out of this and actually pick up their lives without being put under pressure and maybe threatened of losing the job or having hours cut, everything. So I just think it's really important.
Good question, Jane, thank you. I'll take Heather first in answering it and then Sam.
Thank you. So again, Sheffield Psychology Board at the start of pandemic did a lot of work together to give advice and psychological wellbeing advice that we targeted at certain groups, so people with learning disability, people with autism, dementia. I think what we need to do is revisit that information that went out and how we can get to people. But for example, we delivered to supermarkets, 30 different supermarkets across the city, a whole bunch of information, thanks to public health colleagues that were helping us do that. In terms of how we come out of lockdown, I think it is going to be extremely challenging. Again, the IAPT service have tried to do reach out programs to employers, but I think that is something that we need to work with a number of partners across the city, IAPT, the VCF sector, South Yorkshire Housing, that are doing a lot of employment support in this space. And I think we do need to think about how we can offer targeted support. The other thing that it's probably just worth saying, and it's a mantra that we've developed, first of all, it's okay not to be okay. We've all gone through this pandemic. If there's any one of us here that says I'm not impacted, then we've either got a secret stash of many millions away that's helped us to cushion us from the blow, but everybody's been impacted. And that's sort of, it's okay not to feel okay. The fact that it's perfectly acceptable to have bad days and good days, and that doesn't mean that you're developing a mental illness. However, what we need to do is make people able to access some of the materials that can help them to manage and to become self-aware about how to manage their mental well-being. And I would really urge, and probably, Mike, I'm stealing your organisation's thunder, but we commission you, so I'm allowed to, I think. The Sheffield IAP website is absolutely superb. There is some absolutely brilliant material on there that's around self-help. There are groups that you can join in on. There's online materials. I really would encourage all of you to have a look at those materials and signpost some of the people that you represent to those materials. Again, I know this is website based. We have also developed the Sheffield, thank you, Steve's just putting on information about the leaflets that I'm talking about that the Sheffield Psychology Board developed on Sheffield Flourish. There's also information on Sheffield Flourish about the Sheffield Mental Health Guide. And again, that continually gets updated. As part of the primary care mental health project that we've talked about a few minutes ago, we've actually developed that into a physical paper guide that has been delivered across the city as well. But I guess it's that thought that we won't come out of this unscathed as a population. And what we need to try to do, though, is make people feel it's okay not to be okay. Seek help, seek guidance, seek that health and wellbeing support that's available. And then we need to be targeting programmes to people that do need that additional support, such as the primary care mental health programme that we've described in IAPT.
Thank you, Sam. You wanted to come in, and then Steve. I'll take
Yes.
Sam and then Steve, please.
Thank you, Chair. So I mean, Heather said quite a bit of what I was going to say, actually. So she sort of got in there before me, which is fine. I think what I was just going to add is a sort of note of caution about the whole narrative about recovery and coming out of lockdown. And I think Councillor Dunn's point is a really good one. But so all-encompassing, it becomes a bit overwhelming when you start to think about whose job is it to do all of that, to make everyone feel okay about coming out of lockdown. And I guess it's as a committee, you can't do it alone. We can't do it alone as commissioners. It's a national narrative, I think, that we've got a local role to play in, and it's very much a public health narrative that we're trying to achieve together on this. I think the note of caution, picking up, I think, on a bit of one of Mike's points, was we have to be really careful in the balance with this narrative that we aren't inadvertently medicalizing what is a normal reaction to a really terrible international global event. So people who lose their jobs or kids are anxious about going back to school, that's not a mental illness. It's something that actually, as a society, we've got to develop resilience and good narratives to support our colleagues, our families, and our friends and our communities. And then there's an element of all that which is about what are our services doing to support the people that have developed a mental illness or more of a serious mental health problem as a result of that. So it's a real combination of things going on there, which are kind of big narrative stuff which we can contribute to, but then some really specific service delivery that can grow and respond to those needs as they start to emerge.
Thank you for that, Sam. Steve, you wanted to come in on this?
Well, I am going to start by saying
so far.
I'm going to start by saying sort of exactly what Sam said, which is he's just said what I was going to say. So Heather, Sam, Steve, that's great. Absolutely, I wanted to really pick up more on that sort of pathologizing, sort of non-medicalizing, sort of like certain aspects, which doesn't negate or decrease the impact or the severity of what is. I mean, it just means that the perspective is slightly different, isn't it? It's more about how do we as society sort of cope? How do we culturally change a perspective? That doesn't mean to say that when interventions that are sort of necessary to mitigate illnesses, sort of need to happen, then they should happen, of course. And we should be continuing to invest in, sort of in being able to prepare for that. One of the things that the rapid impact assessment, and it's so good that our public health colleagues, Joe and Eleanor here as well, are saying on that population level, that expectation of surge, but there's that preventive element as well. We can still sort of do some of the things that I've put in the chat, sort of educate, bring sort of people's attention sort of to things that are important, just like you know have done, Jane, you know, sort of, and point them in the direction of building resilience. So one of the things that I've put in the chat is about the IAP services coping with COVID. That's being consistently sort of developed. It was initially developed right at the beginning sort of lockdown, saying, well, almost like, what is this and what is lockdown and how are we going to cope with it? But it's building sort of more of that psychological sort of resilience, and that's changing with time. And they're very specifically, and this will be my last point, you mentioned about employers and employers' responsibilities. And I think that, as Sam has said, that will come up from differing sort of like angles. But one of the things that we do have in Sheffield is the Sheffield Occupational Health Advisory Service, which works so closely with IAPT as well, looking particularly at the psychological distress and the mental health support that goes with employment and the risks around the challenges around sort of employment. And I've put the web links up there as well. Thank you.
Mike Hunter, please. You wanted to come in on this question?
Yes, please. I'm being quite frequently asked questions along the lines of, well, you're an expert, what's the impact of COVID on mental health? And the sort of stock answer is, well, actually, that's an easy question because it's more of everything. We're seeing people who've been well for years and years and years become very unwell. We're seeing people who've never been unwell before become really unwell to the extent that they need specialist secondary care inpatient treatment. We're seeing people who haven't been unwell before developing common mental health problems, the sort that normally people seek help for in primary care and community settings. We know that and this is going back to what Sam was saying, we see lots of people not getting mental health problems, but being under the kind of psychological strain that we know will be helped by psychological and social support and those kind of high level public health and educational type interventions that can be made. So it's more of everything, and we'll need more to be able to do it properly. And I'm not arguing this from a kind of parochial secondary care provider point of view. I mean that the mental health of the country across that whole range of settings and intensities and so on will need more if we're going to do it well, in the same way that the economy has to be supported in a particular way to be able to offset the effects of a pandemic. People's mental health in all of those different layers, it will need to be supported in a similar way.
I mean, the bottom line is, if we can't help people to re-engage, they will actually have a higher level of need, won't they, for potentially medical services and so on as well, without pathologising it at the moment. People who've been, in particular, shielding for a long period of time, that's going to be really, really tough, isn't it? So anybody else want to, Jane, did you want to come back on that at all? I think that's a really good discussion. I'm going to bring you in, Gary. Is this on this point you want to? I'll let Jane come back in, and then I'll bring you in if you want to contribute.
Yeah, no, thank you very much. And it is for people that wouldn't even know about IAP, the ordinary person. And it is actually exactly what Mike said, is nipping this and letting people know, because I think the expectation, this is going to be great, it's going to be a party. And if you suddenly feel that you can't, then people will go, oh, you must be nuts. People use language like that. It's inappropriate, because everybody is different. So we need to kind of get this messaging. It's a layering message. We're an amazing city, and how we handle everything. And I think one thing, we as a city, every single one of us and every organisation has to help come out of that. And I think that will probably be one of our biggest challenges. But thank you for what you've, how you've responded. It's really good.
Thank you, Jane. Gary, did you want to come in on this point? And then I'm going to take Angela.
Yes, thanks, Chair. It was just, nobody took my thunder, by the way. I just want to say that. Chair, the things what's in the chat, I'm not going to write them all down. I just wondered if somebody could send them all to us later on.
You can save it yourself if you want, but we will save them. Little buttons down the bottom. If you click on that, you can save the chat.
I'm not that IT.
Okay.
I'm just no. There's one, thank you. There's just one worry here. I mean, fantastic. Thanks for everybody who spoke on this. But it's going to be reading the report next year that we find out, you know, what has actually happened and everything we have put in place and try to avoid what we're all thinking what might be happening. Thanks.
Thank you. Councillor Angela Gentio, you wanted to come in, I think. I can't hear you.
I think what I wanted, I hadn't asked to ask a question, and I think what I was going to ask has already been answered. Thank you.
Okay, thank you. Anybody else want to comment or ask a question? Colette?
Thanks. I just wanted to respond to Gary's point around kind of what we will be looking back on this time next year. And I think I do think that's one of the strengths of the voluntary sector, and that they're out there in the community and they're a fantastic kind of like temperature check as to like small changes as to what's happening across different communities. They have the reach into different communities, they have that trust, they have those relationships. And it's through those channels that kind of preventative work and kind of normalization of like people's responses to coming out of COVID, the COVID roadmap, and all those other kind of non-medicalization of normal responses to things. All of that messaging can be kind of like dispersed through like different channels, but also through the voluntary sector. So I do think there's work that can be done across the voluntary sector around supporting people around that kind of preventative agenda. So stopping kind of people's kind of mental health distress at this time from escalating. Yeah.
Thank you, that's really helpful suggestion. I'd just like to sort of point out though that the voluntary sector groups aren't evenly distributed across the city. And in some areas that you know, there's many more vibrant groups, greater levels of capacity and stuff than others. So we always need to be mindful of that as well. Thank you. Anybody else? Because I've got some questions. I'm guessing from, although we haven't specifically talked about it, Colette talked about things basically have got a lot worse under this lockdown. Basically, I just wondered whether there was any data in terms of the and the original sort of projections and discussions about modelling, which were in the paper, which were really very much earlier on in the process, whether or not things have moved on, i.e. have we got higher levels than we originally predicted at the moment in terms of mental health issues and distress. I don't know if we've got any other, what Colette gave us was sort of qualitative, but I just wondered in terms of, I don't know whether anybody, I was going to ask you, Mike, whether or not you, Mike Hunter, whether or not that the sense of you know, demand for services as opposed to what we've been talking about is sort of is distress and what's a sort of quite a normal reaction to difficult circumstances.
So I'll confine my answer to what you might call the very acute end, and what we've seen in secondary care. We've seen a dramatic increase in the numbers of referrals for assessments for detention under the Mental Health Act. And we've seen a very large increase in the number of people brought in by the police to our place of safety on the Section 136. Section 136 is a police officer's power, if you like, to be able to take someone who appears to be in a state of mental distress or severe mental disorder, who's in a public place, to a place of safety. And that's gone very high in recent months. I realise that's at one end of the spectrum. That's a slightly different question, but that's one.
No, it's. I was just trying to get a sense. I'm not surprised that some of this has happened, but on the other hand, we're making assumptions, and that's why I'm asking the question. So thank you for that. Sam, and then Heather, please. Sam,
yes, thanks, Kate. So coincidentally, we've been talking, some of us colleagues, with our public health colleagues just this week about the fiendish difficulty of trying to forecast what what COVID will do to demand for mental health services. There weren't back in August and the autumn, but there are now some emerging toolkits that some different areas or research organisations have started to produce, which are starting to be used by bits of the NHS and some local areas to try and do some local kind of modelling of actually where demand might start to emerge over the coming months and years. I think it is very, very difficult. I think even our public health colleagues themselves, when they look at the models, go, it's based on lots of assumptions, isn't it? And inevitably they will be. But I think our message is we don't want to wait a year and then go, well, it all looked really bad, but we knew it was going to be bad. We didn't know how much, so we waited to see. So I think our intention as joint commissioning, and I guess as a system, is to try and get ahead of that demand before it comes and invest in the right places so that we can at least try and mitigate some of the extra pressures. Things have got worse. Mike's talked about the acute end. From a council social care perspective, our spend has gone up over by about £700,000-800,000 this year than it was originally planned to. It's really hard to say exactly how much of that is directly related to COVID, because obviously the system, people are moving around the system all the time for all kinds of reasons. But what seems to be the case is that people are still moving through the system on a recovery basis, but they're particularly around home support for social care needs are getting higher, so there are higher cost packages of care for people, and I think that'll be related to the fact that people are stuck at home. They can't do some of the activities that they would normally do that might keep them in a reasonably stable state. So people are entering into crisis a lot more than they were previously, and that must be, we think, COVID related. So there is some modelling that we're going to start to do, acknowledging that that might not be perfect, and we'll have to just keep a really close eye on things as they emerge. But yeah, there's definitely big pressure in the system. I don't know whether CCG colleagues might want to talk about the possibility of NHS funding being increased, in order to anticipate some of this demand, because I know there's been some.
Thank you. I was going to ask questions about funding as well, so maybe Heather could cover that at the same time. Thank you. Heather,
on mute, Heather.
Unmute yourself, please. Heather, you're still muted.
I'm sorry, I was pressing my button.
Oh,
that's it. Sorry about that. So there is an indication from the spending review that there will be some additional money coming for mental health service investment. We anticipate that might mean around 5 million for Sheffield. With the number of pressures that we've been outlining today, clearly that won't go far, and that will be across sort of adults and children's services. But as Sam said, we will be working. We've got a really good joint commissioning plan together where we know where our priorities are. We're meeting with our providers to look at their pressures, to look at where investment's going to make a difference. And we're working up that against the sort of national long-term plan, what we're expected and where we're expected to invest. So just to give a few examples, for example, mental health, perinatal mental health services we need to invest in. We're expected to invest further in the individual placement support employment service for people with mental health conditions. We're expected to be looking at some services around children's support, and we are looking particularly around crisis intervention there as part of our crisis transformation programme. So I think last time, Chair, the intention was for Scrutiny to write to the government to sort of raise concerns about mental health funding, and I'm sure that would be still much appreciated, but certainly there is some money coming. We'll see how much we actually get allocated to Sheffield.
Thank you, Heather. I'm going to take George next on this. Councillor George Lindis-Hammond.
Thank you, Chair. I just wanted to come really briefly before the meeting end, just to say how much I've really valued the points that have been made today, really, particularly on many of the pressures. The pressures around IAPT, I think, it particularly struck me because I know that's something when I was on this committee, which seems like a few years ago now, that was very much something that was an issue then. And I think as we go forward in a joint commissioning world, we really have to make sure that it's not just about trying to improve services and really focusing on trying to maintain our services as you've seen with this hugely increased pressure, but actually really communicating what we're doing well, because I think when we see problems occurring in services which are very front-facing, it can sometimes start to undermine the faith we need from people of Sheffield that we can work together to make Sheffield a more mentally healthy city. So I think it should be a focus of all of us to really try and stamp on problems with those more front-facing services, because I think we need to do that in order to increase the faith in all the services we're trying to provide in very difficult times. So I appreciate all the contributions today. They've been very valuable. Thank you.
Thank you. Martin, you wanted to ask a question or make a comment?
A question, if I can just nick in, because you actually reminded me, Chair, of the question I was going to ask and didn't. It's around the unequal provision of in the VCF sector. So I was just wondering, and this is, I guess, probably more at not so much at Colette, but actually more widely, what is the council and what is the NHS doing to address this through increased VCF funding? Because I saw that was mentioned in the report. Are we specifically targeting the areas that don't have good VCF coverage at the moment, or most importantly, in greatest needs, to aim for a more equitable coverage of that? How are we basically supporting a more equitable coverage and addressing the holes that we currently have? Thanks.
Is this question specifically around COVID recovery, or is it actually a wider question around generally building capacity in the community and voluntary sector, just so that people can respond to it, Martin?
I guess it's a more broad question, really, isn't it? Because it's come up a few times in scrutiny sessions over the years.
Okay, did anybody from the NHS or Heather? Something seems to be going a bit wobbly with you at the moment, but when you
said... Sorry, I've just had to move just due to noise in the house that I thought might be distracting, but then realised I put my camera on by accident as I was moving. We have put some investment into the voluntary sector over the last year through COVID, about around 120,000. That doesn't sound a lot to me. But what we have done, and Colette has been really helpful in getting together with our partners in the voluntary sector to help us make bids for some funding streams to NHS England. And in fact, whilst we've been on air, I've just seen a little bit of information that we've been successful in one of those bids around looking at crisis buddies, for example. And the intention is that we will work with voluntary sector organisations to place those crisis buddies into organisations that are in, if you like, are in the front of this. I think your question about are we looking at the coverage of voluntary sector organisations in the city, I think that's a really good one that I haven't personally thought of, and Sam, you and I need to speak further about that with Colette in terms of what the coverage is. But I think what we're trying to do is get a closer relationship with the voluntary sector so that we're actually collaborating more and trying to develop bids together and trying to include the voluntary sector, and then trying to invest where we can when we get that additional money too. And it always feels not enough, but I think that is changing. We've got a sea change where we are trying to look more to the voluntary sector.
Thank you. I mean, it does sound like, you know, from that you have actually made a lot of progress, Heather, so well done for that. Maybe as we're all saying, we're not doing enough, we need to do more, but that we can't, you know, we have to acknowledge where improvements and change have taken place. Steve, you indicated, did you want to come in on this?
Yeah, just two quick points. One specifically about a strategic approach to the VCSE. And my understanding is that the Accountable Care Partnership sort of holds, so the ACP sort of has a strategic sort of position and is working together sort of with the with VCSE colleagues who are members of the Accountable Care Partnership as well, about looking at that approach to Sheffield as a whole. Very specifically, though, my second point is that picking up on the primary care mental health framework, the one that has been described earlier on, where sort of now in 4 primary care networks covering 200,000 of the population, the VCSE sort of, colleagues are working sort of into that programme, and £300,000 has been invested into that programme specifically sort of for delivery through sort of VCSE colleagues.
Thank you. To be honest, Martin, I can't tell you how much the council's putting into to the voluntary sector. It's millions and millions, and we have invested a lot more money actually during COVID as well. And there's another round of bidding as well to help with the recovery process. So I can't tell you that because I'm not the lead on it, but also we put money into the voluntary sector through so many different directorates and so on. So for example, like People Keeping Well programs, as well as specific funding to individual organisations. But definitely, I think we all value our own community and voluntary sector, particularly as local councils. I do think there is a point, though, that when people start talking about mental health support across the city and all these wonderful organisations, that I think we need to actually think about the coverage of those organisations, and that there are some quite big organisations, and there are other areas where, in fact, we do not have the capacity for some of this stuff. So. Colette, you're going to tell me I'm wrong.
So I wasn't necessarily going to tell you wrong. I was going to provide a different perspective, which is I'm not sure if this conversation has been kind of focused on maybe geographical communities, because an awful lot of organisations that provide mental health support provide that support across the city. So there's citywide organisations. Now that's not to say that there might still be kind of colder spots and kind of warmer spots as to their reach, but many of the mental health organisations do have like a citywide coverage. So I think there's potentially different perspectives. I know there's like local geographical community organisations that there's the People Keeping Well framework, and my understanding of that is that there is kind of the coverage across the whole of the city. So potentially it's a conversation that requires more than the 2 minutes that we have left of the meeting.
Absolutely, you're absolutely right. As a local councillor, obviously, I'm very much aware of it, and so will all the others as well. So, but I think there's just the point that you know, we have to, if we're talking about prevention, it actually needs to be working with communities, and so we do need a network. That's great, and thank you for that comment. Right, okay. Any last minute comments or questions before I draw this session to a close? No. Can I just thank everybody who's contributed? There's been a really interesting session, and it's well worth actually inviting you back for an update and so on. And there's a lot of stuff, you know, we've come up with very thought-provoking, and particularly the whole issue about recovery and how collectively we work to promote that. And I'm just sort of thinking about where we're going to get leadership on that and getting the messages. And it is a public health message, isn't it? But I think there's obviously some further thought needs to be given to that as well. So thank you very much for the papers and for your contributions and for coming to talk to us today. So I'm sure again it will probably be on next year's work plan as well. But thank you.
Thank you for having us, Chair.
Yes,
thank you for having us.
Thank you indeed. Bye-bye.
Bye.
I need to give apologies. I need to leave now, Kate.
Okay. The next item on the agendas won't be a long one at all, because basically this is a report of a session that we've already had. We wanted to share with the whole of Scrutiny. I did want anybody who was at the meeting, either Lucy or Angela, would you just like to say a few words about what we did? Emily's done a great paper on it, but I just wondered whether you would just like to comment at all. You don't have to.
I just want to say thank you for all the work that's gone that went into the report that was presented to that meeting, and it was very, very interesting. It was a very positive meeting, and I think the suggestions or the recommendations that with the changes are very positive, and you know, especially in terms of looking forward. So thank you.
Thank you for that, Angela. I would concur with that. So what you've got is the report, which was a bit of engagement work, a really good detailed piece of engagement work with recommendations, and we went through those, and we've already started to take some actions on some of those. Lucy, did you want to comment?
Yeah, just a really quick thing, and it is reflected in the what Emily's written, but just to highlight that the report is really evidence that we pulled together from stuff that you already had. So it wasn't a kind of piece of work that we set out to do in a planned way, and hence we do really want to acknowledge that there are some significant gaps in there and some areas that probably need more exploration, including in fact the kind of response and the work that maybe services were already doing to address some of the issues that isn't in the report because of the nature of the work that you know, we did to sort of put that together. But yeah, just to highlight that.
I think it was, as I'd just like to reiterate as well what Angela said, it was a really valuable piece of work, and it was a, you know, really good discussion on it. If anybody's got, you know, we're happy to take any questions on the work at all. It's not for a big debate today, but if anybody's got any questions or comments on it, no, okay. So what we're asking you to do is just to receive and note the report and the recommendations and the action and the discussion which arising from the subgroup meeting, and at some time in the future. We're not programming it because we can't really program for next year, but for suggesting that we have another discussion about it at some stage in the future. So that's what you're being asked to endorse. Is everybody happy to do that? That's great, thank you very much. Well, the item on the work programme is not going to take very long, is it? So actually, I'd just like to say then that, you know, we've had a, you know, really, we've worked hard this year. We've had 9 meetings since we started again in June. I hope you've felt the meetings have been useful and valuable. I think we've worked really hard, actually. I'd just like to sort of say au revoir to anybody who's definitely not going to be here next year, and that includes my colleague Lewis Dacknell. He definitely won't be here next year. For the rest of us, for all sorts of other reasons, it's less certain. Is anybody else here standing down? I don't think so. No, I don't mean just Lewis, but only Lewis. So I'd like to thank all the officers who've done an incredible amount of work this year. Emily in particular has just really been a right powerhouse and so on, getting all the, you know, working with me in particular to get all the papers together and so on. You've done a fabulous job, Emily, thank you. I'm going to mention my mother in a minute, although she's no longer with us, but I just felt we should actually have closure for what's been a really hard, a year of very difficult year for everybody, and we've tried very hard to respond to it. So thank you very much, Jenny, as well, for your contributions and your questions and all the funny stuff with the IT going wrong as well. It's just been hilarious, hasn't it, at times? So, Jane, did you want to say something?
Yeah, I wanted to thank you, Chair, for making this so productive. And I think it's been really inclusive, and I know just how much work has gone into it. And I echo what you've just said, but I honestly think you've been really fair, firm, but I think it's just been brilliant, you know, kind of the people that we've had around the table and the discussions. And I think the public can really see how well we can all work together on this as well. So thank you very much. I've really enjoyed it.
Can I endorse that? Yeah, absolutely.
Okay, well, on that note of cross-party agreement, we'll head off into the elections. So thanks very much, everybody. And
thank you, Chair.
Yeah, take care. Bye.
Bye, everybody.
Bye, everybody. Thank you.
Bye.